Hello everyone, I'm here on Medico Academy to deliver this lecture on the basic modes of mechanical ventilation. As mechanical ventilation is widely practiced in anesthesiology and critical care, as postgraduate students, a thorough understanding of the basic modes of mechanical ventilation is very important. So let's move on to the slides. So mechanical ventilation, in short, is the delivery of positive pressure breaths to the airways and alveoli, and this can be achieved through invasive or non-invasive methods. In invasive mechanical ventilation, positive pressure breaths are delivered to the airways with the help of invasive airway devices such as endotracheal tubes or tracheostomy tubes. Whereas in non-invasive mechanical ventilation, we deliver this positive pressure breaths to the patient via non-invasive airway devices such as face masks or NIV helmets or hoods. There is a separate lecture on non-invasive mechanical ventilation which you can refer to later. So when you switch on the ventilator to deliver mechanical ventilation, either by invasive or non-invasive methods, what you usually see is a list of modes usually pop up on the screen. So you need to know what exactly is a mode and what are the different kinds of modes and what are the modes to be used in specific situations. So what do you mean by a mode of ventilation? A very simple definition would be a mode of ventilation is nothing but a pattern in which positive pressure breaths are delivered to a patient. And each mode of ventilation is characterized by a group of different ventilator variables that are set in varying combinations and patterns depending on the type of mode that you use. So the most simple definition of mode would be it's just a pattern in which positive pressure breaths are delivered to a patient. So let's see what are the different ventilator variables that we set on a ventilator in different modes. The various variables include respiratory rate, tidal volume, inspiratory pressure, inspiratory flow, inspiratory time or inspiratory pause, IE ratio or the ratio between inspiratory time and expiratory time, PEEP or the positive end expiratory pressure, and inspiratory trigger. In addition to this, we also have the option of setting FiO2 or the fraction of inspired oxygen on the ventilator. So as we said, since a mode is a pattern in which positive pressure breaths are delivered to the patient, we should have an idea what are the different kinds of breaths that can be delivered to a patient. So there are three different kinds of breaths when it comes to mechanical ventilation. They are controlled breaths and assisted breaths, which are mandatory breaths delivered by the ventilator. And the third kind is called the supported breaths. Usually, they are the breaths, the spontaneous breaths that are supported by the ventilator. So the major part of work in controlled breaths and assisted breaths is by the ventilator. And the major part of work during supported breaths is usually by the patient. So let's see each breath in detail. Controlled breaths, as the name itself indicates, are completely controlled by the ventilator and they're delivered at set time intervals. For example, if we set a ventilator rate of 15 breaths per minute, that means in a minute, that is 60 seconds, 15 breaths have to be delivered to the patient. So by simple calculation, 60 seconds divided by 15 breaths, that is 4. So every 4 seconds or at a set time interval of 4 seconds, one mechanical ventilatory breath will be delivered to the patient. In this, the patient has absolutely no role or patient does absolutely no work, and it is the ventilator that does all the work. So this is a simple pressure time graph where pressure is on the vertical axis and time on the horizontal axis. You can see that it is a controlled breath that is delivered to the ventilator, where the ventilator decides when to deliver the breath, at what pressure or what volume or what flow the breath is to be delivered, what is the inspiratory time, etc. is also decided by the ventilator. So it's under the complete control of the ventilator. So that's a control breath. Now let's move on to the next type of mandatory breath, which is called the assisted breath. An assisted breath will be delivered if the patient attempts to trigger a breath from the ventilator side. That is, a good example would be a patient who is just coming out of muscle relaxant or sedation and he just starts taking a breath. So in such cases, the ventilator will sense that inspiratory effort by the patient, which is called the triggering event. So ventilator will sense this trigger and then the ventilator completely takes over and then gives a full breath, which is almost similar to a controlled breath. So this is the pressure time graph again, where you can see that there is a small dip in the baseline pressure because of the inspiratory effort by the patient, which acts as a trigger for the ventilator. The ventilator then completely takes over and delivers a complete breath to the patient. So these two, controlled breaths and assisted breaths, are mandatory breaths by the ventilator, where the major role is played by the ventilator. In supported breaths, the breath is again triggered by patient effort, but the ventilator provides only partial support to the patient. It does not provide full support like that happens in an assisted breath. So it looks almost similar to an assisted breath, but the major work is by the patient and less work is by the ventilator. So let me give you a good example of a controlled breath. When you anesthetize a patient, you first give an induction agent, you check for ventilation, and then you give a muscle relaxant. And once you give a muscle relaxant, you intubate the patient as the patient is completely paralyzed. And then either the anesthetist manually ventilates the patient or you connect the patient's endotracheal tube to a mechanical ventilator, which is a part of your anesthesia machine. So in such cases, you can see that the patient has absolutely no role. You are the one who decides how much tidal volume should be administered to the patient, at what rate, with what inspiratory time, or what volume is to be delivered to the patient. Everything is decided by you or the ventilator. So that's a typical example of a controlled breath. An assisted breath is when the patient is coming out of the muscle relaxant. You can sense that if you're ventilating manually, especially, you can sense that inspiratory effort on your bag, on your ventilation bag. So then you completely take over and give a full breath to the patient, because you know that the patient is not strong enough yet to take over his ventilation completely. But when the patient has been given reversal from the muscle relaxation, and the patient starts taking breaths of his own with sufficient effort, there you will be just supporting his breaths, right, with your bag and mask. With your anesthesia circuit bag. So in such cases, those breaths are called supported breaths. So these are the three basic kinds of breaths that you'll be delivering using a mechanical ventilator. So this is again a pressure time graph which shows the controlled breaths. This is another pressure time graph which shows assisted breaths, which show that dip which is happening, a dip in the pressure which happens because of the negative pressure created by the patient's inspiratory effort. So now let's move on to the basic phase variables in a breath. Each breath is characterized by three basic phase variables. So in this pressure time graph, I have marked it as A, B, and C. Let's go in detail to these. The first variable, or A, is called the trigger variable. Trigger variable means it acts as a trigger of the gun. That is what initiates the breath. So as you saw in an assisted breath, it is the patient's effort that triggers the ventilator, right? So in an assisted breath, it's the patient who creates the trigger. So it's either a drop in the flow or a drop in the pressure that is sensed by the ventilator, and then the ventilator starts the mechanical breath. So we'll come to the trigger variable in detail later in the following slides. So whatever initiates the breath, that variable which initiates the breath is called a trigger variable. In a controlled breath, it is the time which triggers the breath because you have set a particular rate. As I said in my earlier example, every 4 seconds you have to deliver a breath means it is the time. That is, every 4 seconds you are delivering a breath. That means it's the time which is the trigger variable. Now B is called the limit variable. What is the target that is to be achieved? That is called the limit variable. For example, in a pressure targeted breaths, it is the pressure which is targeted. When the airway pressure reaches a particular value, then there is no further rise in gas flows from the ventilator. That is called a limit variable. So what is the target to be achieved or what limits further rise in gas flows? That is called the limit variable. If you have a pressure targeted mode, then pressure is the limit variable. If it's a volume targeted mode where you have set the maximum volume should be this much only, then volume is the limit variable. Now the third one, or C, is called the cycle variable. See, when you deliver mechanical ventilatory breath to a patient, it cannot keep going on and on forever. At some point, the expiration has to start, right? So for that particular variable which decides when should the ventilator cycle from inspiration to expiration, that is called a cycle variable. A good example would be if you take a controlled breath, for example, where you have set the rate, inspiratory time, pressure, etc. So when that particular inspiratory time is over, suppose you have kept an inspiratory time of 1.2 seconds. So once 1.2 seconds have lapsed, the ventilator will cycle back to expiration. So that is called a cycle variable. So cycle variable can be time or flow in some modes, whereas in control breaths, it's usually time, which is the cycle variable. So these are the three basic phase variables in a breath: trigger variable, limit variable, and cycle variable. Why these phase variables are important? Because this is the way you describe breaths on a mechanical ventilator, and that when you know to describe a breath, you will know better about a mode which you are using. And it also becomes easier or helpful in deciding which mode you have to use in a particular case. So each breath can be described by these three phase variables. So trigger can be either a machine triggered breath or a patient triggered breath. So if it is a machine triggered breath, it's usually a time triggered breath. If it's a patient triggered breath, then it's usually the drop in flow in the ventilator circuit or a drop in pressure in the ventilatory circuit that acts as a trigger. So we'll go in detail about this trigger in the coming slides. So let's see what is a limit variable, which is usually said. As I said earlier, it's either pressure or volume. In a pressure targeted mode, it's the pressure which is the limit variable. In volume targeted mode, it is the volume which is the limit variable. And in dual modes, both can act as limit variables. And cycle variable, in most of the controlled breaths that are delivered, it is the time which acts as the cycle variable. Whereas in certain other modes like pressure support ventilation, it is the flow or the decrease in flow to a particular level that acts as the cycle variable. So now, this is a basic diagram of a ventilator circuit. This is the inspiratory limb through which fresh gases flow to the patient, and then the expired gases flow towards the expiratory limb, and it is near the expiratory limb that you have a flow sensor as well as the pressure sensor. So there is something known as the base flow. During that period when there is absolutely no effort or no breaths being delivered to the patient, there is a constant flow which happens from the inspiratory limb to the expiratory limb. This is usually around 10 liters per minute. So that is called the base flow. So whatever goes from the inspiratory limb goes back to the patient. So if 10 liter per minute flow is going through the inspiratory limb, when there is no flow occurring to the patient, 10 liters per minute comes back to the expiratory limb, which is sensed by the flow sensor or the pressure sensor. But what happens when there is an effort from the patient side? When there is an effort from the patient side, a portion of this gas flows into the patient. So whatever comes back to the patient will only be the leftover, right? So when the ventilator tries to detect the base flow, it senses a drop in this base flow. So the initial base flow was 10 liter per minute, which was returning to the sensor. But now, since the patient has started taking an effort, it has sensed that there is a drop in the base flow. So when the inspiratory effort reaches to that value of the trigger variable that you have set, then the demand valve opens and a breath is delivered to the patient. So that is the idea of a trigger. Suppose you have set a trigger value of 3 liter per minute. So when the patient starts taking a small breath, it will be hardly 1 or 2 liters per minute. The ventilator is not going to give any breath to the patient. But when the patient makes an effort good enough to create a flow of 3 liter per minute or more than that, then the valve opens and a mechanical breath will be delivered to the patient. So that is the concept of trigger. So a drop in flow or a drop in pressure because of the inspiratory effort of the patient is sensed by the ventilator, and then the valve opens and delivers a complete mechanical breath to the patient, or even a supported breath to a patient. So that is the concept of trigger. So now, how do you classify the various modes that are available? A very simple way of classifying modes is based on the limit variable. What is the limit variable of that particular mode? If it's a pressure, that is the limit variable, then it's a pressure targeted mode. If it's volume, that is a limit variable, then it's a volume targeted mode. If you can use both pressure and volume as the limit variables in certain newer modes, then they are dual modes or hybrid modes. So basically, we can classify modes based on the limit variable. So this is a pressure, flow, volume versus time graph of a pressure targeted mode. As you can see that after the peak flow is reached, the pressure remains constant, whereas the volume keeps changing. So in a pressure targeted mode, you have control only on the pressure. There is absolutely no control on the volume being delivered to the patient. So whatever be the ventilator, whatever be the compliance or whatever, the patient will receive a mechanical ventilator breath at a particular pressure. So this in such modes, we have no control over the volume that is being delivered. So this can result in volume trauma, resulting in pneumothorax. Now, how about a volume targeted mode? Again, this is a pressure, flow, and volume versus time graph, where you can see that you have set a particular volume. So a volume is reached, a target volume is reached, and the volume remains constant throughout the end of inspiration, but the pressure keeps changing. So here you have no control over the pressure, though you have a control over the volume. So in such cases, there is a propensity for the patient to develop barotrauma in the form of pneumothorax or pneumomediastinum usually. And there are dual modes in which you can control both pressure as well as volume so as to avoid barotrauma as well as volume trauma. The examples of dual modes are pressure regulated volume control mode or the PRVC mode and volume assured pressure support, which is VAPS. So now there are different ventilators available in the world and different modes in each ventilator. So there'll be different modes like this. There's a huge set of modes available, a huge list of modes available. So as postgraduate students, you need to have an idea about the basic modes of mechanical ventilation, such as an assist control. It can be pressure targeted or volume targeted assist control, SIMV or synchronized intermittent mandatory ventilation, pressure support ventilation, and CPAP or continuous positive airway pressure. Other modes such as BiPAP or biphasic positive airway pressure, APRV or airway pressure release ventilation, PRVC, pressure regulated volume control, or adaptive support ventilation, these are a bit advanced modes. There is a separate lecture on advanced modes of mechanical ventilation, but in this lecture, we will concentrate on the basic modes of mechanical ventilation, namely the first four. So the first mode, assist control mode. To understand what's an assist control mode, we need to know what is a controlled mandatory ventilation. Controlled mandatory ventilation is nothing but the delivery of controlled breaths. I've already shown you the graph of controlled breaths. So when these breaths, controlled breaths, are delivered at set or fixed regular intervals, then it is called controlled mandatory ventilation. Patient has absolutely no role at all in this mode of ventilation, and the ventilator continues to give mandatory breaths irrespective of what the patient is doing. If the patient starts breathing, then there can be asynchrony or fights between the patient and the ventilator. So this is an outdated mode. We don't use controlled mandatory ventilation these days. So now they came with a modification of this, which is called the assist control mode. So this is again a graph of controlled mode. Now in this graph, pressure time graph, you can see that the first two breaths are controlled breaths. That is, there was no effort from the patient side at all. So this is a typical example. When you have paralyzed the patient and put the patient on a mechanical ventilator, all the breaths will be controlled breaths. So here you can see that the first two breaths were controlled breaths, but then you can see that there is an inspiratory effort from the patient's side. So when the patient started breathing or patient started making an inspiratory effort, the ventilator gave an assisted breath. So again, if the patient goes back to the paralyzed mode, suppose you give another dose of muscle relaxant and the patient goes back to a state of no breaths, then the ventilator will give control modes. That is, in an assist control mode, the ventilator will switch back and forth between a controlled mode and an assisted mode. So ventilator can give controlled breaths as well as assisted breath depending upon the inspiratory effort from the patient side. So this mode is known as an assist control mode. It can be either pressure targeted or volume targeted. The graph that I have represented now is that of a pressure targeted assist control mode, where the pressure is remaining constant. So the modes that we use these days are assist control modes, where we use minimal muscle relaxant and we give more of sedation to the patient. So when the patient has few small breathing efforts, the ventilator will deliver assisted breaths to the patient. In case the patient loses the inspiratory effort due to some reason, then it will provide control breaths. So that is known as an assist control mode. So what's the difference between a control mode and an assist control mode? The trigger is different. In control mode, it is the time or the machine which triggers the breath, whereas in assist control mode, it is either the machine or the patient. If it's the machine, then it is the time that triggers the breath. If it's the patient, then it's either the drop in flow or pressure that triggers the breath. In both cases, the limit will be either pressure or volume, and the cycle variable will be time. That is, after a particular inspiratory time, the ventilator will cycle back to expiration. So the next mode is SIMV, or synchronized intermittent mandatory ventilation. To understand what is an SIMV, we need to know first what is IMV, or intermittent mandatory ventilation. So this is also an outdated mode, intermittent mandatory ventilation. It used to be used previously, where there would be spontaneous breaths in between the mandatory breaths. As you can see that the blue magenta graphs are inspiratory mandatory breaths by the ventilator, whereas the red and green ones are spontaneous breaths by the patient. So in between, you can see that the dotted lines are the places where spontaneous breaths should have happened, but because of the mandatory breaths delivered by the patient, that did not happen. Also, you can see at the time of 4 seconds, there was a spontaneous breath here. Then there was expiration happening. And in the middle of the expiration, you can see that there is a mandatory breath which is delivered to the patient. That is, when the patient was trying to expire outward, there was a ventilatory breath which was coming inward. Also, during that 7th second in the graph, you can see that the patient completed his inspiration, his lungs are full. And before he could start expiring, there is an inward mandatory breath which is coming to the patient. So this results in a lot of problems. So in intermittent mandatory ventilation, you see that periodic breaths are delivered at set time intervals. That is, it will be time triggered and it can be volume targeted or pressure targeted breaths. And between the mandatory breaths, you saw that the patient could breathe spontaneously, unlike the controlled mandatory ventilation, where the patient could never breathe in between those mandatory breaths. There was no role by the patient. So in intermittent mandatory ventilation, there are controlled breaths which are delivered at set time intervals, but between these set mandatory breaths, the patient was allowed to breathe spontaneously. So let's see this graph again. So here you can see that there is something called breath stacking which has happened. That is, usually the patient has already taken a breath and the lung is filled with a particular amount of air. Again, now another breath, mechanical breath, is again filling up the lungs. So there is breath stacking. Also, you can see that in the last controlled breath that you see, the patient was inspiring and his next phase was to expire, but instead inspiration has happened. So basically there is asynchrony also happening. So the problems with intermittent mandatory ventilation were breath stacking and asynchrony. So to get rid of this problem, scientists came up with newer mode, which was a modified mode called the synchronized intermittent mandatory ventilation, or SIMV. So let's see how SIMV is better than IMV. So in SIMV, ventilator delivers mandatory breaths at fixed time intervals and also allows spontaneous breaths in between mandatory breaths as in that IMV mode. But the difference is that, let's see. So this is a controlled breath, again a spontaneous breath, spontaneous breath. Now this is an assisted breath, again a spontaneous breath. Now again an assisted breath because the patient took a ventilatory effort. So if there is no inspiratory effort by the patient in between the spontaneous breath, then SIMV delivers controlled breaths. What if the patient has an inspiratory effort, especially during a period called the trigger window? We'll come to talk about the trigger window in the following slides. So if there is no inspiratory effort by the patient, controlled breaths will be delivered and in between will allow spontaneous breaths. But if there is an inspiratory effort by the patient, especially during trigger window, then assisted breaths will be delivered to the patient. So because of this synchronization of the ventilator breaths with patient's inspiratory efforts, there is no breath stacking. The disadvantages of IMV were mainly asynchrony between the patient and the ventilator, and breath stacking. So these two are avoided with the use of synchronized intermittent mandatory ventilation. So let me show you the difference between IMV and SIMV. So in IMV, all the mandatory breaths are all controlled breaths, that is time triggered, pressure or volume targeted, and time cycled. Whereas in SIMV, The mandatory breaths can be either controlled breaths or assisted breaths. Controlled breaths if there is no effort from the patient side during trigger window, and assisted breaths if there is a effort from the patient side during trigger window. So mandatory breaths in SIMV can be controlled as well as assisted, and they can be time triggered or patient triggered and time cycled. So that is a difference between IMV and SIMV. So in IMV, there is breath stacking and asynchrony, whereas in SIMV, this is taken care of. So what is a trigger window? A trigger window is also known as a synchronization window. In this graph, I have marked the trigger window as sky blue rectangular boxes. As you can see, these trigger windows are placed just prior to the delivery of controlled breaths, right? So the trigger window is usually some 0.3 to 0.5 seconds prior to a controlled breath. So trigger window is that time interval just prior to the scheduled delivery of the time triggered mandatory breath. And it is during this window period, the ventilator is responsive to the patient's spontaneous inspiratory efforts. I'll show you. So now we can see that the patient started an inspiratory effort during the trigger window. So the ventilator has sensed it. So instead of, waiting to give the controlled breath, the ventilator gives an assisted breath a little prior to the scheduled mandatory breath. So that portion or that time interval just prior to the delivery of a mandatory breath or a scheduled mandatory breath, during which the ventilator is responsive or sensitive to the patient's inspiratory efforts, is called a trigger window. So in the next you can see that if the patient fails to initiate ventilation within this trigger window, suppose there is no inspiratory effort from the patient side during the trigger window, then what? Then nothing. The ventilator will wait till the end of the trigger window and it will provide a controlled breath. So that is the concept of trigger window. Trigger window basically helps in synchronization. So again, this graph shows how a trigger window works. So if the inspiratory effort occurs during trigger window, whatever ventilator delivers will be an assisted breath. What if there is no inspiratory effort at all during trigger window? Then a controlled breath is delivered after the trigger window. What if the patient starts breathing after trigger window? Then there is no problem at all because the ventilator has already started giving inspiratory flows to the patient. So there is inward inspiratory flow from the ventilator to the patient. Even if the patient starts breathing, it's fine because it is synchronized with the patient's inspiratory effort. There is no fight between the patient and the ventilator that the patient wants to expire and the ventilator wants to inspire. There is absolutely no fight or asynchrony between the patient and the ventilator. How about the patient having inspiratory efforts between the controlled or assisted breath and the trigger window? Then there a spontaneous breath is allowed. So that is what happens in SIMV. So in SIMV, in short, there will be mandatory breaths at fixed time intervals, which will be delivered to the patient. In between the mandatory breaths, the patient can breathe spontaneously. If the patient makes an inspiratory effort during the trigger window, then the ventilator will synchronize it and give an assisted breath. If there is no effort from the patient side, then the ventilator will wait till the end of the trigger window and give a controlled breath. So that's about SIMV. So SIMV can be used when the patient is out of deep sedation and muscle relaxant. It is still being used quite commonly as a start point of weaning the patient from ventilator. So the third mode that we are going to discuss is pressure support ventilation. So in pressure support ventilation, it's purely spontaneous. All breaths are by the patient, so that it's the patient who determines the respiratory rate and hence the minute ventilation. Usually pressure support ventilations are pressure targeted or pressure limited. So the pressure is decided by you, but the respiratory rate and minute ventilation will be solely decided by the patient. So this is also used as a weaning mode. So this is again a pressure flow versus time graph, where you can see that all inspiratory efforts, you can see the dotted lines which are negative efforts from the patient side, negative pressure efforts from the patient side. So all the efforts have been triggered by the patient. The pressure, final pressure achieved is the pressure that you've set on the ventilator, and then the ventilator cycles back to expiration when a particular flow rate is reached. So we'll go into that in detail. So this pressure support ventilation is a purely spontaneous mode where the patient decides what is the respiratory rate and the minute ventilation. So in this graph, you can see that inspiration now cycles to expiration. So here the trigger is by the patient. It is either the drop in flow or the drop in pressure in the airway that is sensed by the ventilator. The limit variable is the pressure in pressure supported ventilation, whereas the cycle variable is the flow. As you can see that when the flow drops to a certain percentage of the peak flow, in this picture, it is 30%. When the flow has dropped to 30% of the peak flow, the ventilator cycles back to expiration. So in pressure support mode, it is a patient-triggered breath. The limit variable is the pressure, and the ventilator cycles back to expiration depending on the flow. So there is no single flow cycle percent that is right for all patients. So depending on each patient, depending on each patient's condition and disease state, you have to adjust that percentage of peak flow as the cycle variable. Usually it is set between 15 to 30%. So what is the difference between a pressure assist control mode and a pressure support mode? So in pressure assist control, it is either the machine which triggers or the patient which triggers the breath. So if it is machine triggered, then it's time triggered. If it's patient triggered, it's flow or pressure that is a trigger variable. Whereas in pressure support, it's always the patient who triggers the breath. It is the drop in flow or drop in pressure which triggers the breath. The limit is the same in both modes. Pressure is the limit in both modes. How about the cycle? It's a cycle, which is cycle variable, which is different. In pressure assist control, it's the time. After a particular inspiratory time, it will cycle back to expiration. But in a pressure support mode, since the patient is in control of whatever is happening, the patient decides in the respiratory rate, right? So it is the flow that cycles cycles from inspiration to expiration. When the flow decreases to a particular percentage of the peak flow, the ventilator cycles back to expiration. So PSV is usually used for spontaneous breathing trials during weaning and extubation, unlike the previous two modes, namely controlled mandatory ventilation or assist control modes or IMV or SIMV, where we use those modes in the initial stages of mechanical ventilation, where you want the ventilator to take full control and give less role to the patient. You want to put the respiratory muscles to rest. In such cases, you use those previous modes like IMV, SIMV, assist controls, and controlled modes. Whereas pressure support ventilation is used for spontaneous breathing trials, it can also be used as a non-invasive mechanical ventilation mode. NIV PSV can be used in patients to reduce the work of breathing, and also it can be used to improve ventilation and oxygenation in selected cases. These have been discussed in the lecture on non-invasive ventilation. So PSV can also be set during any mode that allows spontaneous breaths. For example, SIMV, we saw that there are mandatory breaths in the form of controlled breaths and assisted breaths. But in between, the patient is breathing spontaneously. So if you apply this pressure support during this spontaneous breaths as a ventilator setting, then those spontaneous breaths can be supported. So those spontaneous breaths become supported modes. This is basically done to provide uniform ventilation. That is, when you have controlled breaths, you have good tidal volumes, but during spontaneous breaths, you have very low tidal volumes. So, there won't be uniformity between the breaths that go to the alveoli. So to provide uniformity, you can provide support to the spontaneous breaths so that the tidal volumes will be almost equal during all breaths, during supported, controlled, as well as assisted breaths. So that's the use of pressure support ventilation. So now let's go to the last mode, continuous positive airway pressure, or the CPAP. See, normally when your patient breathes spontaneously, this is the pressure time graph. That is, 0 is usually taken as the baseline airway pressure. 0. When the patient breathes at atmospheric pressure, it's usually arbitrarily taken as 0. So the inspiration will be below 0 and expiration will be above 0. So that is how a normal spontaneous breathing occurs. But if you apply a CPAP for example, 5 centimeters of water, then the entire baseline airway pressure of the patient is taken to a higher level. It's taken to 5 centimeters of water, and the breaths will be taken at that baseline. So most of the time, there will be no negative pressure in the airway. So that is called continuous positive airway pressure, where the baseline airway pressure is taken above 0. So CPAP elevates the baseline airway pressure to a positive value, and the patient breathes spontaneously above and below that value. So the advantages are they keep the airways open, improves FRC, or the functional residual capacity, and this can thereby improve oxygenation by preventing alveolar collapse. So that's the advantage of using CPAP. CPAP can be combined with pressure support ventilation. So in pressure support ventilation, if you keep a CPAP or a PEEP and then a pressure support, then the patient will be taking supported breaths above this particular positive airway pressure. There is a separate lecture on how to set a ventilator. In that, I'll be describing in detail about each ventilator setting. So now let's come to the patient comfort level as the last slide. Suppose if you scale patient comfort level from 0 to 10, so where will these all modes that we learned now will come at? So controlled mandatory ventilation is not a comfortable mode for the patient because the patient has to fight with the ventilator. So it comes at a lower level. So then came the assist controlled ventilation, where the patient has some synchrony in the sense that at least the patient's effort is acknowledged and then a ventilator breath is given to the patients. But this is also not very comfortable, especially if the patient is awake. So in these two modes, CMV and assist controlled ventilation, you have to deeply sedate the patient, or in some cases even paralyze the patient using neuromuscular blocking agents. Then came the SIMV, which was a bit more comfortable because spontaneous breaths were being allowed in between. Also, there was synchronization of the mandatory breaths with the patient breaths. Yes, then came the PSV and the CPAP, where all the efforts were by the patient and there was only partial support by the ventilator. Majority of the support was by the patient himself. And the last would be spontaneous breathing, where the patient would be absolutely comfortable. So if you take patient comfort level into account, it will be CMV, then assist control, then SIMV, then PSV, CPAP, and spontaneous breathing. So when you put a patient on ventilator because of ARDS or COPD, acute exacerbation or whatever, initially you will have to use some assist control mode, sedate the patient deeply, achieve your goals, achieve your tidal volume, achieve your pressures, and achieve your oxygenation as well as carbon dioxide levels by serially monitoring the arterial blood gases and vital parameters and the ventilatory parameters. Then you slowly start weaning the patient depending on your comfort level using SIMV or a spontaneous breathing trial on pressure support ventilation. And once the patient is ready for extubation, that is when the patient fulfills all the extubation criteria, then the patient is extubated. So that is how the various modes work. So that is all about the basic modes of mechanical ventilation. There is a separate lecture on advanced modes of mechanical ventilation and how to set a ventilator. Thank you very much for your patient listening.